Welcome everyone to Temple and Wescoe Foundation ILD seminar. Like I had mentioned, we are incredibly privileged to have you with us. We have a lot of information to cover. So I just want to take a second and just thank Temple Lung Center. It's an honor to be able to host our ILD seminar this afternoon. This is near and dear to us at Wescoe Foundation. My name is Jennifer Wescoe, Executive Director of Wescoe Foundation for Pulmonary Fibrosis. Worked with Temple Lung Center for many, many years. And so we're just truly honored to be a part of this seminar. I also would like to thank Boehringer Ingelheim for sponsoring this event and for their support. So thank you so much to Boehringer Ingelheim, or BI, as you guys I'm sure have heard many of times. At the end, we are going to have a Q&A. Originally, this was going to be an hour. We elongated to another half hour so we can optimize that time to ask questions. It's really important for us to have that dynamic information conversation. So at the end, that'll be about 1:20. Okay, so it's going to be about a half hour longer. So make sure, again, you write those questions down and we'll be able to address them. If we don't address them during that time, we'll make sure that we follow up and get you in the direction or ask these questions and help you along the way. Lastly, we're going to have a follow-up email. This event, seminar event, is recorded. So this is wonderful that you guys could go back to it and make sure you assess things that you might have missed or review. Like I said, this information is very important. Knowledge is power. The topics that we're going to be covering are understanding interstitial lung disease and associated conditions. Another topic, this is progressive, managing symptoms and oxygen management as well. We're going to have a sponsor presentation from Boehringer Ingelheim, our clinical nurse educator, Erin Chinock, understanding your PFTs, or pulmonary function tests. Pulmonary rehab and lifestyle adjustments, paramount for quality of life. Next presentation is treatment options and clinical trials. The second last one is patient and care partner support and ways to navigate it and ways to live with interstitial lung disease. And the last one is lung transplantation. So those are the topics that we'll be addressing, and that will ease into a live Q&A. In closing remarks, and make sure we have our follow-up items. If I didn't mention, we will have a survey to follow up. Make sure we are moving on the way that you all are looking for and what we can continue and do better. Without further ado, we will be starting the sessions. And the first one, like I had mentioned, is understanding interstitial lung disease, ILD, and associated conditions. And the presenter is Parag Desai, and we can get that started.
Welcome everyone to the ILD patient seminar. My name is Parag Desai. I'm one of the professors in thoracic medicine surgery at Temple Lung Center. And I'm going to be speaking to you about what is ILD, or interstitial lung disease, and understanding your diagnosis. So interstitial lung disease really is a catch-all term for several diseases that cause both inflammation that can lead to scarring and or fibrosis of the lung. I tend to call it the alphabet soup or lung world because of the various names, as we'll kind of discuss, we kind of encompass in this umbrella term of interstitial lung disease. To understand interstitial lung disease, let's describe the normal lung. On the left, we have a picture of a normal lung that's full of little balloons or normal air sacs. The job there is to exchange gases, breathe in oxygen, breathe out carbon dioxide. In between the air sacs is areas that we call the interstitium. And this is really where interstitial lung disease has its beginnings and inflammation. The model you can use is kind of a sponge, where the air sacs in the sponge do the normal job. The rest of the sponge is the interstitium. And when you get diseased, that sponge becomes hardened. You can't squeeze it as much anymore. It's harder to use, and that's what interstitial lung disease is. This is another pictorial kind of describing the same structure. On the left, you have the trachea that then splits into the various bronchi or airways in the lungs that then further get smaller into the bronchioles, which end in the air sac. And the space, kind of this light green, is the interstitium. And on the right, you can see that the interstitium, once it gets scarred, becomes thick, and it causes problems with exchange of gases. When we look at a CAT scan, on the left, you see a healthy lung. Everything in black here is the right lung. Here is the left lung. You have some airways coursing through it, but this looks like a healthy lung. And when we look on the right, you kind of see that sponge, or the lung that's become hardened and coarser, defined by kind of these white, bright lines going through each of the lungs. What causes interstitial lung disease? It's really some injury from various different mechanisms, either from breathing in a toxin, medication, something that we're working with, that causes inflammation. That inflammation leads the body to start a repair process. And an abnormal or overly active repair process can then lead to scarring or fibrosis in the lung. And I kind of put this arrow in the middle because oftentimes this process is repetitive, where additional injury tends to occur. Again, it could be from various different mechanisms, which you can lead to various abnormal repair processes and causing fibrosis. This diagram's complex. We don't need to memorize all of it, but what we do need to understand is that there are many different pathways that are co-dependent and interactive that lead to fibrosis. So in the early phase, you have your factors that define us, either environmental risk factors, smoking, occupational exposure, viral infections, what makes us in terms of where we're in terms of our aging, what a genetic predisposition is, whether or not there's persistent exposure, if there's some autoimmunity, which then leads to various different mechanisms through fibrosis. And sometimes this fibrosis in and of itself is self-progressing. It manifests itself in different ways. Early inflammation can represent itself as a granuloma, where the body's kind of formed a wall around the injurious mechanisms. NSIP, or non-specific interstitial pneumonia, fibroblastic foci, and then honeycombing, or really the fibrosis that we see. We don't know all the specifics, all the pathway, but we're catching up and we're learning more as each day goes by. I like this picture from CHEST that they put out a few years ago. It kind of describes a tree. You kind of have the basic of the tree is interstitial lung disease. And then each of the branches are the different causes of interstitial lung disease. So here you have your pneumoconiosis, whether I worked with asbestos in my life or my partner or loved one worked with asbestos, whether I exposed to silica or beryllium in my exposure. Granulomatous disease, such as sarcoidosis or hypersensitivity, without some medications, such as antibiotics like nitrofurantoin, chemotherapy, amiodarone for my heart disease. Do I have autoimmunity that presents itself in the sense of collagen vascular disease? There's some that are unclassifiable. Cryptogenic organizing pneumonia could be more of an acute presentation. This is where I come in. My CAT scan is an abnormal picture, and oftentimes that's how we find out you have ILD. You have idiopathic variant, where we don't know of any known causes, but they tend to progress over time. And then there are some rarer causes, such as lymphangioliomyomatosis or amyloidosis, that can also cause interstitial lung disease. And then you have smoking-related diseases. So outside of COPD, emphysema, smoking itself can cause a host of interstitial lung disease. This is just kind of putting that tree in a different mode, going through autoimmune causes. So rheumatoid arthritis is a good model, because sometimes even before the arthritic symptoms, the joint symptoms are seen, we can see that it's affecting the lung. Scleroderma or systemic sclerosis is another one, where oftentimes there is a lung variant as well. From an occupational standpoint, I've kind of mentioned work with asbestos, work with silica, working in a coal factory and metals. Environmental is important. Exposure to mold, exposure to bird droppings and feathers. If you've been involved with raising birds or chicken coops, you could be at risk. Folks who've had parakeets through life and have other genetic predisposition can get hypersensitivity pneumonitis. Others we've kind of talked about and touched on the previous slide. And then idiopathic variant, kind of a way of saying we don't know the exact true mechanism, but we've ruled out other mechanisms to cause it, of which, IPF or idiopathic pulmonary fibrosis is the most common. So statistics, overall, it's kind of a rare disease, less than 1% of the US population in 2021 for the last demographics that we have. Average age is about 69. So this is a, disease that predominantly happens later in life, but we can see it early in age as well. We tend to see an increasing incidence with age. It is even in terms of female and males until the 7th decade of life, when there's more males than females. Median survival for idiopathic pulmonary fibrosis and non-idiopathic pulmonary fibrosis is about 2 to 5 years, with the median being about 4 years. This will change as the data gets updated with use of medications that we have at present, and also early recognition of the disease. In summary, it's a rare, aggressive lung disease, and the worsening fibrosis on CAT scan with worsening respiratory symptoms and lung decline tends to denote a worsening prognosis. What symptoms do we have? In a textbook world, you'll see progressive shortness of breath, persistent dry cough, and fatigue. But we have to account for patients who start accommodating for their symptoms. 1 minute, they were able to walk up a hill, go down 9 holes of the golf course, and then over time they notice that those 9 holes are taking a bit longer. Going up the hill is taking a bit longer. I have a story of a young male who came to see me, who was playing baseball, was able to push the stroller with his 2 twins, and then within a year started noticing, pushing the stroller up a hill was just getting harder. And in baseball, he couldn't run the outfield as well. And that was the beginning of his journey with, interstitial lung disease from rheumatoid arthritis. And we have to kind of look for this accommodating for symptoms. There's unintentional weight loss, and subtleties, can't use the push mower, taking more frequent breaks. And oftentimes our loved ones are the ones who pick up on this and not the patient themselves. So you have a progressive shortness of breath, persistent dry cough, and fatigue is kind of the umbrella, and then we have to look underneath it. Diagnosis. I would say the gold standard is we need a CAT scan. Chest x-rays are good. They give us some information, but a CAT scan of the chest really does give us the information we need in terms of how to group the diagnosis, what differentials or different disease processes to think of, and then also in terms of management. Is there more inflammation? Is there more fibrosis or scar? We need pulmonary function testing and 6-minute walk test to understand how much the fibrosis inflammation has affected lung function. Are we, and how much lung function that we have to preserve as we go on time. Labs to either confirm or rule out diagnosis. I always say this to my patients. We use labs to kind of screen as to see what may be inflammatory cause and how to control it and what to follow, but is never diagnostic of the disease in and of itself. Oftentimes we get asked, should we do a biopsy? What is the role of biopsy in diagnosing interstitial lung disease? Most of the time, at least my own practice and those of my colleagues, if we have a good CAT scan of the chest, if there is a good history, we can often defer the biopsy, particularly now with good thoracic radiologists, multidisciplinary discussion, we can obviate the need for biopsy. Biopsy does become important if we're trying to exclude cancer or infection, maybe in certain disease such as sarcoidosis. The one question we always ask ourselves before we put anyone through a biopsy is, will it change my management? Is the result of the biopsy going to mean different treatment that I offer to the patient? If the answer is no, then the risk of the biopsy may be not the benefit to the information it provides us. What are those risks? Either collapse of the lung or pneumothorax, bleeding, and in some cases of fibrotic lung disease and idiopathic pulmonary fibrosis, it can cause a flare or worsening of the disease just through the biopsy process in and of itself. And so this is a case-by-case discussion with the patients. So this is just to give a sense of the HRCT or high-res CAT scan of the chest and how it can help us. This kind of is a pictorial representation of, based on what we see on the CAT scan and the different patterns that we see, it'll give us a sense of what the diagnosis may be. Management really comes down to two big principles. There's inflammation, there's scarring, and the role is, if we find inflammation, what can we do to decrease the inflammation? If there's scarring seen and it's progressing over time, can we get you started on medication to either prevent scarring over time? We know there's no cure, so the goals really become slow down disease progression and then decrease the risk of flares or acute flare-up. So again, you have a patient on the left here who has a flare. You see a lot of graying on the CAT scan, these bright white lines are the blood vessels, but in the background here's a lot of gray. With treatment, you kind of see less of the gray in active treatment. Monitoring comes down to getting pulmonary function testing, seeing a pulmonologist frequently. Onset, we get pulmonary function testing and a walk test. And then my practice is to repeat it every 3 months from the onset of your diagnosis to see, A, is there a progression despite treatment? Is there stability on treatment? Or is there some improvement on treatment? Because each of those things are going to denote what we do next, i.e., if there's stability, continue plan, continue to monitor. If there's worsening despite treatment, do I opt for transplant? Do I opt to change my therapy, so on and so forth? Management is multifactorial. Use of medications such as anti-inflammatories and antifibrotics. I'll put clinical research trials right here because, as we've referred to before, there's significant amount of research that's now coming into play in terms of what pathways of inflammation to target. So as I embark on medications, oftentimes we're having a discussion about where clinical research trials play a role. Use of supplemental oxygen in those that need it. I often say that it's more for the health of other organs, in particular the heart, the brain, more so than the lung disease itself, and the importance of supplemental oxygen as such. Pulmonary rehab. It's the catch-22 before you get the lung transplant is the stronger you are, the better any future therapy is going to be. So I think the help of pulmonary rehab is there's a social aspect in patients working with other patients with similar diagnoses. The importance of moving and muscle health and the impact of a lung disease on the skeletal system. Lung transplantation as an avenue for treatment once other treatment paradigms have failed or the disease tends to progress. And then the importance of support groups in terms of a coexistence amongst patients and learning from one another. Oftentimes, we have to use vaccinations, particularly if I have you on anti-inflammatories or even in those with idiopathic and just on antifibrotic, the prevention of any viral infection in terms of progression of your lung disease. Thank you very much.
Hi, Ernie, could you unlock the video? Hi, everyone. Yes, that was an excellent, excellent presentation. So informative. Thank you so much, Dr. Desai. We have new folks coming into our session. this afternoon. Make sure you have your notes ready to go. This is a wealth of information. So welcome. We're so happy you're with us. Next presentation, we are talking about symptom and oxygen management. So very important for our quality of life. And Dr. Aamir Ajmeri will be presenting.
Good afternoon, everybody. My name is Aamir Ajmeri. I'm a pulmonary and critical care physician here at Temple. Today, I'm going to talk about symptom and oxygen management. All right, so most people know that when we're talking about treating patients with interstitial lung disease or idiopathic pulmonary fibrosis, we're kind of focused more on the disease itself. We're focused on treating, either the inflammation that's undergoing, or we're treating the fibrosis that's propagating. But we're kind of now focusing our attention more so on, of course, treating the disease, but also treating other things that are underlying for patients, things that may be outside the lung or things that may be contributing to other symptoms and things that may worsen lung function. So I think this is a nice diagram here, which kind of outlines the things that we're focusing on. So over here, we see that the disease modifying treatment, of course, is, medications, anti-inflammatory, anti-fibrotic medications, clinical trials. But we're kind of going to focus on these two red boxes here, talking about oxygen, talking about psychological support, what to do about some other comorbid symptoms that patients often experience who are afflicted with interstitial lung disease. So I wanted to talk about oxygen for a bit. So oxygen desaturation, it contributes to decreased exercise tolerance. So as many of you know, is that once you get diagnosed with an ILD and you do have hypoxemia, meaning that your oxygen levels are low, it becomes difficult to exercise. And when you start doing less and less exercise, then your muscles start atrophying, and it's kind of a use it or lose it situation. And for patients who already have limitations with bringing in oxygen and already shortness of breath, the muscle atrophy worsens all of that. So it's really important to continue as much exercise as possible. So patients who were given supplemental oxygen, they were able to walk farther, reducing their shortness of breath scores, reducing their fatigue scores. And then a lot of patients felt different about using supplemental oxygen when they saw that they were able to do more exercise. It also leads to decreased amount of cough. There's a lot of things that people think about when using oxygen. So the fear of running out, embarrassment of being seen with it in public, thinking about the disease is worsening with the use of oxygen, or unsure about how much or what to do about it. But, I think what I always tell patients who use supplemental oxygen, who kind of talk about these concerns with me, is that it's not something that is going to hold you back or something that will allow you to do less, but it's something that will allow you to do more activity and allow you to lead a more active and full life. So to kind of shift that mindset and stop thinking about it in terms of, oh, I need to get off the oxygen, I need to stop using it. No, you use it, and you use it to help you live a more normal life. There's a couple things about oxygen. There's when we talk about it, there's flow, which is either continuous, which is constant, or pulse, where it gives you a little bit of supplemental oxygen when you take a breath. The prescription that we write is when to use it, either all the time, at night, the amount of flow in liters, and the type of equipment. And there's a couple of different types of equipments that we'll look at in a second. So here's the stationary concentrator that's at home. It uses electricity and pulls oxygen from the air, and it goes from low flow all the way to high flow amounts, like 10 to 12 liters, and you get long tubing that can go all throughout your home. Liquid oxygen is not that common. It's more cumbersome. It needs to be refilled weekly. Insurance doesn't often cover it. But more so often we use compressed gas, so portable tanks where we can have rolling tanks or backpack tanks, and the concentrators are allow usually 3 liters continuous or 6 liters to 9 liters on pulsed flow. Again, more portable concentrators. And then liquid portable concentrators are not used too often, again, because they need to be refilled all the time. And this is the nasal cannula tubing, which goes in the nose, and the tubing can be pretty long, can go up to 25 to 50 feet. So again, most patients will feel short of breath. And what are the things that we can do about this chronic dyspnea, chronic breathlessness? You know, we often refer patients to pulmonary rehab to, again, increase exercise tolerance. In real kind of end stage situations, we can use opiates or medications to kind of decrease the air hunger. And that's a discussion amongst you and your pulmonary team. Cough is also very common in patients with interstitial lung disease. There's a lot of things that go into cough. So it can be from the lung disease itself. It can be from acid reflux, allergies. There's medications that we can use to decrease the cough. When we've kind of treated all the underlying things, there are kind of neuromodulators that we can try to help. And then there are some clinical trials undergoing for patients with cough as their predominant symptom of their ILD. I spend a lot of time talking about acid reflux with patients with interstitial lung disease. It's very, very common. It can lead to progression of the disease itself. A couple of things that are important are, of course, medications, PPIs and H2 blockers like omeprazole and famotidine. The other two big things are keeping your head of your bed elevated at least 30 degrees when sleeping. It's just by gravity to allow the acid to kind of go down into the digestive system instead of coming up into the lung. Avoiding triggering foods like tomatoes, mint, chocolate, spicy, greasy, fatty foods. And then allowing time to empty. So no eating or drinking at least 2 to 3 hours after your last meal before you lie down to sleep. In real severe cases, we refer patients for anti-reflux surgery. Sleep apnea is very common in patients with interstitial lung disease. It's not necessarily in patients with obesity, but it can worsen lung function over time. So we do routinely refer patients for sleep studies who have interstitial lung disease as well. And the last thing I just wanted to touch on was the mental health aspect of this, is that, you know, interstitial lung disease, you have a lot of symptoms, and one of the biggest things is chronic breathlessness, shortness of breath. But it's a terrible cycle, because then you start feeling anxious about being short of breath, and then you become more short of breath, and the activity decreases, and then you're feeling worse because your muscles are getting weaker. So it's just this vicious cycle, and it's really important to kind of talk about these symptoms with each patient. And often we will refer patients for mental health resources, so therapists, psychiatrists, to help with kind of the anxiety and depression aspect of it, because it does go into the symptoms of breathlessness. And then we also work closely with the palliative care team for patients to help with more in detail symptom management, and then of course end of life planning. And so those are the couple of things that I wanted to touch about in terms of symptom and oxygen management for patients with chronic interstitial lung disease. Thank you.
Thank you so much, Dr. Ajmeri. Again, a wealth of information. I often hear the words throughout the presentations, and you'll hear this through each one, the quality of life and moving forward, living with ILD. The next presentation we have is about pulmonary rehab and lifestyle adjustments. And Dr. Pourshahid will be presenting about pulmonary rehab and how we adjust in daily life.
Hello, thank you so much for having me. I'm Omid Pourshahid. I'm a pulmonary critical care physician, and I'm the medical director of pulmonary rehab at Temple Lung Center. I'm excited to talk to you about the role of pulmonary rehabilitation in ILD. My conflict of interest about pulmonary rehab is the fact that I'm a huge fan of pulmonary rehab, and I'm a co-founder of a small company called My Virtual PR, which is focused about pulmonary rehab. So what is pulmonary rehab? Pulmonary rehab is a comprehensive intervention. It is based on a very thorough patient assessment followed by patient-tailored therapies. And that includes, but not limited to, exercise training, education, behavioral changes. The whole idea is to improve the physical and psychological conditions of patients with chronic respiratory diseases to promote long-term adherence to healthy behaviors for these patients. So this definition came from American Thoracic Society in 2013. This is more like a conceptual definition. In order to exactly tell you what is in the pulmonary rehab, here are some of the core components of pulmonary rehab. It usually starts with a comprehensive patient assessment and education in the fields that are necessary. There's going to be a physical activity coaching and maintenance planning. There's going to be structured, progressive, and individually tailored exercise program for resistance training, endurance training. There's going to be nutritional assessment and sometimes advice and therapy if needed, specifically in the cases of sarcopenia, malnutrition, unintentional weight loss, which is unfortunately very common in all patients with chronic respiratory diseases, including ILDs. It also includes a section for psychosocial support, self-management techniques, and it has sections for measuring the outcomes, how well they are doing and how effective it is for the patients. So there's going to be a lot of talks about interstitial lung disease, but it wouldn't be a proper talk without at least mentioning it. That interstitial lung disease, it would be a very diverse group of conditions. It may involve varying degrees of inflammation and fibrosis, not necessarily all, but like most of these interstitial lung disease, they could have these conditions. And in majority of cases with interstitial lung disease, there is reduced lung compliance, impairment of gas exchange, and this subsequently leads to increased dyspnea or breathlessness. And unfortunately, when a patient starts to feel this shortness of breath or breathlessness, this promotes activity avoidance. A lot of times this is started with exertion, so they try to avoid it, and the more they avoid it, they're going to have more muscle deconditioning, further worsening of breathlessness, and further loss of functional status. As you see this spiral, they could go two ways. There is no stability in it. They either have to push back and they start to try to gradually work on it and gradually get better slowly and fight against that shortness of breath and breathlessness that usually starts with activity, or if they give in, if they start to basically surrender to their disease, this is gradually going to get worse, and the more deconditioned they become, the more short of breath they'll become. So some of the benefits of pulmonary rehab: it reduces this dyspnea, it increases exercise capacity, it improves health-related quality of life, it helps with the social support. Specifically for patients with COPD, there are studies that it shows reducing hospital admission and even mortality risk after hospitalization. But that is not necessarily something that has been studied in interstitial lung disease, not that it does not exist. As I said, it used to be pulmonary rehab, it used to be mainly offered to COPD patients. Not necessarily because there is something very specific about COPD and pulmonary rehab, but part of it was that this was the most common and basically most prominent disease. So there were more studies on it. But now benefits of pulmonary rehab is recognized in many other chronic respiratory diseases, including interstitial lung disease. Other diseases that were not initially offered pulmonary rehab, but now they are being recommended to go for pulmonary rehab, like pulmonary hypertension, bronchiectasis, asthma, lung cancer, some patients recovering from advanced thoracic surgeries like lung transplant, or some severe respiratory diseases that affect their respiratory system like COVID. And Since this is on the newer side, like a lot of people know COPD with pulmonary rehab, here are some of the evidence that I picked for you. This is not the only evidence, but to put it into a perspective, these are meta-analysis from multiple randomized clinical trials. It shows significant improvement of 6-minute walk test. There was about 40-meter improvement, and that is not just a significant improvement and just a number from a statistical standpoint. This is a significant clinical change as well for better. Dyspnea scores, it was showing that is improving for patients who've completed a pulmonary rehab course versus the ones who are not. About like 350 patients that were pulled from the randomized clinical trials. Health-related quality of life, how much their patient life is affected by their disease. And it's showing that this number is reducing, meaning that the disease is having less effect on their behavior, on their perceived quality of life, how they feel their life is, and how much it is affected by their disease is reduced overall, meaning that the quality of life is improved. And good thing about it is that these benefits were sustained for up to 12 months post-intervention. Not that it disappeared after that necessarily, but a lot of the studies, they do not have a lot of data after that. And most important thing, no increase in adverse events have been reported. So we have an intervention for patients who are going through this significant disease that improves a lot of aspects of their disease without having a significant adverse events. That sounds like a really, really good intervention. If you put it into comparison with a lot of other interventions, that there is not a lot that can provide something like this with this minimal adverse events. Some of the aspects that pulmonary rehab can help for the daily life adaptations for patients with interstitial lung disease. It helps to improve stamina for basic tasks, and it may not feel like that these little bit of change may mean much, but it helps to maintain independence for a lot of patients, and that's how it significantly improves their quality of life. Use of assistive devices and supplemental oxygen is going to be recommended when they are being exerted to the proper threshold to make sure that they are not exerting themselves too much to cause harm, but at the same time, they are exerting themselves. So it is breaking that vicious cycle of deconditioning and shortness of breath. Other aspect includes behavior modification and reducing the behaviors that triggers the symptoms. Some of it could be psychosocial, anxiety, behavioral technique, breathing techniques. They all could be helping. And in addition to that, the nutritional counseling, supporting energy balance, muscle function. A lot of time, even though they may not look like that, their weight is significantly changing. Their chronic respiratory disease is going to affect the whole body composition. And as a result, a lot of time there is a significant muscle loss, which subsequently is going to worsen their functional status. And the worse that gets, the worse the overall prognosis. So pulmonary rehab is going to fight on multiple fronts for the quality of life of the patient. So to put everything into a quick wrap up, American Thoracic Society is strongly recommending pulmonary rehab for patients with ILD. No significant adverse events were reported. Multiple studies have shown clinically significant reduction in dyspnea, improving exercise tolerance, improving health-related quality of life. Here are some references and appropriate reads in regards to this topic, and I'm ready for any questions or concerns. Thank you so much for your attention.
Thank you so much, Dr. Pourshahid. You know, we are going through each of these sessions, these educational sessions, understanding ILD, symptom oxygen management, understanding what PFTs are, pulmonary function tests, and pulmonary rehab, and adjusting to your quality of life. And so we go through this trajectory of very important information along the way. And part of that too are clinical trials. I always say clinical trials obviously are our future, and research is our future, and also treatment options. So I know we have some few new folks coming with us this afternoon. Thank you for being here. And make sure you get out your notebooks, ask these questions. I already saw a Q&A one, which is brilliant. So we want to make sure this is impactful as possible. Next session is clinical trials and treatment options. And we have Dr. Criner, Dr. Gerard Criner, presenting on this topic.
This slide illustrates how lung fibrosis can occur in some patients that develop interstitial lung disease. It's believed that there is an event that causes either inflammation or an injury to the patient's lung. In patients that have either of these events, there can be repair of the lung and recovery, but in other patients, lung tissue damage results in fibrosis. The pathways to developing fibrosis can be inflammation that does not resolve or inflammation that causes further lung injury. Both mechanisms may result in lung fibrosis. This slide shows the spectrum of interstitial lung diseases that range from inflammation of the lung to fibrosis. Several diseases, such as hypersensitivity or nonspecific pneumonitis, might have more inflammation, or other lung diseases like usual interstitial pneumonitis or IPF may have more scarring, and other diseases like sarcoidosis can have a mixture of both inflammation and scarring. This slide shows the type of anti-inflammatory drugs and antifibrotic drugs that are used in different types of interstitial lung diseases. Some patients will be on both types of therapies, and in most cases, drugs are started sequentially, not simultaneously, to make sure that the patients are tolerating the medications before starting the other class of treatment. This slide shows the goals, drug choice, and duration of treatment for anti-inflammatory drug therapy. The goals of anti-inflammatory therapy is to improve the patient's shortness of breath and try to improve lung function and oxygen needs. The drug choice are the best drugs that can accomplish these goals with the least side effects. Prednisone is the anti-inflammatory drug usually used first, but high dose and long-term is usually associated with significant side effects, and other drugs are used instead that are more effective or as effective with less side effects. This slide highlights what the most important questions that patients have about using drugs to treat idiopathic pulmonary fibrosis. Patients usually want to know if and how the antifibrotic drugs will benefit them, and if there are other new drugs that are being studied to help treat this disease. Common questions center around: will the antifibrotic drugs improve lung function, improve survival, or make them feel better? That is, less short of breath during their activities of daily living. This slide shows the results of the two approved drugs on decreasing the progression of lung function reduction over time: Ofev, or nintedanib, on the left side of the slide, and Esbriet, the generic name is pirfenidone, on the right side of the slide. As one can see, the rate of reduction in lung function over time is approximately the same for both drugs in their pivotal controlled trials used for FDA drug registration. About 50% reduction in decline of forced vital capacity, or FVC, with either drug. As one can see, the most common adverse reactions associated with Ofev are diarrhea, about 50% of patients in the clinical trials, nausea, and vomiting. Drug discontinuation rates in a clinical trial was 19.3%. With Esbriet, also common GI reactions are found. In addition, photosensitivity skin rash may occur. Drug discontinuation rates were about 14% in the ASCEND and CAPACITY trials. This slide shows that these drugs have been shown to be beneficial in other types of lung fibrotic diseases. This slide shows the beneficial effects in patients with lung fibrosis due to scleroderma, a form of connective tissue disease. As one can see, there is a similar reduction in decreasing the loss of lung function over time with nintedanib compared to placebo in this randomized controlled trial. This slide shows what we had talked about previously. that in some patients with lung fibrosis, they have a combination of inflammatory and fibrotic progression that impairs lung function. Both processes occur at the same time. As this slide shows, some of those patients on anti-inflammatory therapy can also have further benefit on lung function over time when an anti-fibrotic agent is added to their treatment regime. Most patients ask, do anti-fibrotic drugs improve lung function in IPF? The answer is yes. Taking the drugs are beneficial for lung function. They attenuate the decline in lung function that occurs, but they don't improve the lung function from the baseline before the patient starts taking the medication. That means it does not reverse the fibrotic process. These data help to answer that important question about the effect of anti-fibrotic therapy on survival. As these data show, for either agent, whether it's nintedanib or Ofev or Esbriet or pirfenidone, patients that take these anti-fibrotic drugs have a significantly less likelihood of having an exacerbation or flare-up of IPF that are very morbid and mortal events in the life of a patient with interstitial lung disease or idiopathic pulmonary fibrosis. So to answer this important question, do anti-fibrotic drugs help me live longer in patients with idiopathic pulmonary fibrosis? The answer is that yes, both drugs decrease the development of acute exacerbations of idiopathic pulmonary fibrosis, and in retrospective pooled analyses, the answer appears to be yes for both drugs. Like many drugs that we use to treat patients with lung disease, both of these drugs, nintedanib or pirfenidone, have side effects. And avoiding side effects is also important for patients, balanced against its efficacy. Nintedanib tends to have diarrhea and nausea more than pirfenidone, but both have that side effect. Pirfenidone also has the side effect of a skin rash that appears to be more common. But the important thing to know is that patients can explore with their physician what drug works best for them and minimizes the side effects that are most important to that individual patient. So patients ask what drug is better. Both drugs appear to decrease the magnitude of loss in lung function equally. Both appear to equally decrease the rate of acute exacerbations of IPF. Both have similar effects on improving survival. Choosing which drug to use most commonly depends on the patient's tolerance and side effect profile. One thing to note in patients who develop pulmonary fibrosis, that as this slide illustrates, there's multiple different targets that may be important in a specific patient's disease. That makes it very challenging to know what is the direct cause of a patient, but it's important for drug development because that allows many different targets to be explored that may improve the patient's outcome. Well, several recent phase 2 and 3 clinical trials for new drugs targeting idiopathic pulmonary fibrosis have failed to meet their primary endpoints. These are names of 5 of the studies recently exploring different target signals for patients with pulmonary fibrosis that have not shown improvements that will allow this to enter into the clinical arena. So why do so many drug trials fail in patients with idiopathic pulmonary fibrosis? I think, as you see from the last slide, it's a complex disease with multiple pathways. There's a discrepancy sometimes between phase 2 and phase 3 study results because these phase 2 studies may have smaller sample sites and fewer study sites than when they're placed into a phase 3 trial. And also, the lack of use of background IPF therapies in the earlier studies may have shown more pronounced effect that may not be significant when it's added on to the approved baseline therapies. The good news is a recent phase 3 study in both patients with idiopathic pulmonary fibrosis and in patients with progressive pulmonary fibrosis has shown that it's met the primary endpoints. the studies called Fibronir IPF, Fibronir ILD, using the generic compound called nerandomilast. This study, in both of these studies, met its primary endpoint in decreasing the decline in forced vital capacity more than patients just taking Esbriet or Ofev or nintedanib by itself. These enrolled large number of patients in multiple study sites throughout the world and tested 2 doses of therapy. It found that the 18 milligram twice daily dose was the most effective. We believe that the full efficacy data will be released soon, and we're hopeful that this will be the next approved drug for patients with pulmonary fibrosis. Well, how effective is nerandomilast in improving lung function in patients with interstitial lung disease? This is data from Ricaldi and colleagues. It was published in the New England Journal of Medicine in 2023. This is results of a 12-week phase 2 study where nerandomilast appeared to stabilize FVC in patients with IPF regardless of background antifibrotic therapy, whether they were already on Ofev or nintedanib or Esbriet or pirfenidone. And we can see from the left side of the graph, in looking at forced vital capacity change over 12 weeks, patients on the nerandomilast group compared to those on the placebo group had a much less decline or maybe a slight increase in FVC compared to decline in FVC in those patients that were not taking nerandomilast. And this looks at the adjusted rate of decline in FVC with the nerandomilast group compared to those who were not taking it over time. So there's many other studies being tried. This is data at Temple Lung Center showing all the open trials we have with patients with interstitial lung diseases, those who have progressive pulmonary fibrosis or those who have idiopathic pulmonary fibrosis, looking at different other factors, whether the patient has UIP, whether a patient has scleroderma or other forms of connective tissue disease, and looking at agents that are oral, inhaled, or injectable, to see if in addition to baseline therapy with nintedanib or pirfenidone, these other agents may have more beneficial effect. So in summary, 2 effective antifibrotic agents for pulmonary fibrosis have been available for over the past decade. Scleroderma with pulmonary fibrosis and other patients with other forms of progressive pulmonary fibrotic lung diseases also benefit from these agents. Both agents used together may be helpful in selected patients, but higher GI side effects make this therapy less tenable in most patients. Additional therapies, like I recently described to you, are being developed to add on to the beneficial effects of current medications. And if you need more information about the available studies that are now examining new drugs, you can reach us at Temple Lung Center via email or call this number. Thanks very much for viewing this video. If you need any other further questions answered for you, please call the numbers provided. Thanks again.
Thank you so much, Dr. Criner. Again, research, clinical trials is our future, and just a wealth of information. Remember, this is going to be recorded, so you'll be able to go back to it and review it. So we go through this whole process and we think about what it is like living with pulmonary fibrosis every day with your family, how it affects you. So I'm going to be presenting about how we're navigating pulmonary fibrosis, ILD, interstitial lung disease, and how we can find the support and the resources of how we are doing that. So I'm going to give that a little time to let it pull up. And so let's see. Here we go. And notice this operative word, and I'm gonna go that go to that point after this one slide. This gentleman right here is my dad, Ron Wescoe. And this is where this all comes from with Wescoe Foundation for Pulmonary Fibrosis, to provide that support, that education, and help navigating pulmonary fibrosis. And so I think it's really important to bring it back home, right? It has to do with what you're dealing with every day as a patient and as a care partner, and all loved ones who are helping their loved one in navigating everything. So we're bringing it back home to my dad, Ron Wescoe, but he, in representing and symbolizing all patients and care partners managing and living with interstitial lung disease or pulmonary fibrosis. Couple of objectives I want to accomplish in this presentation. In managing everything that you have to learn about, talk about, ask questions about, there's also an emotional, practical needs that come along. And that is so, so important in developing that wraparound approach in really optimizing every opportunity that can help you along this process. And also ways of I often see the word coping. I like the word living with ILD. What are these strategies to kind of help you along the way in this comprehensive approach? Also, there's an army behind all of us, and we are have this wonderful opportunity to provide these resources in a Wescoe Foundation, but in a lot of collaborative opportunities and partnerships. So it's always an honor to be a part of that. I am going to bring this right into play. Like I said, this word, this very first word, is living with ILD, interstitial lung disease. And we often talk about the quality of life, right? And so that also comes into play of how we move forward. What can we do to help us the best way possible? So we're diagnosed with ILD, pulmonary fibrosis, and we think to ourselves, well, what's next, right? We talk with a lot of wonderful, wonderful people, and it's scary, right? It's isolating, it's scary, it's uncertainty. So we put this into play. It's really, how am I feeling too? But also, how am I going to get all this information to empower myself, my care partner, and my family, and our complete network to help us navigate everything? So how are we feeling physically? How are we feeling emotionally? But also, what are the ways that we can get this information to empower ourselves moving forward? Education, incredibly important. Support, incredibly important, and resources. So there's a lot out there. So you do not feel isolated or feel alone. So we're lucky to be able to be a part of that. So when we're initially diagnosed with pulmonary fibrosis, I'm using those words interchangeably. Forgive me. You'll hear me say them back and forth. So just make a note of that. Right, we have our initial diagnosis. It's a shock. You know, how do we deal with this? What is it? How do I manage this? And right, we go through this whole process of, feeling scared and worry of what the future holds. And, rationalizing it's, well, what did I do wrong? What happened to make this happen? And sometimes, right, this leans into depression and really feeling lost and how to manage this big picture of everything. And then we kind of get into this place of acceptance. Okay, this is what I am dealt with. These are the things that I am in control of. These are the things I am not in control of. And I'm going to learn and bring in this network to help me along the way. Now, you'll see this as like a progressive type thing. We all know, as we're probably nodding our heads, this is not initial diagnosis, shock dial, worry and fear. It can fluctuate. It can go back and forth. So no, there's no guidebook in this. This is something that you are understanding cognitively, but also knowing this is a process back and forth, and it's okay. You do the best you can every day. So we often, as always, our care partners are so, so important. They're our heroes in this process. I say that all the time. I can't help saying that. They really are just true, incredible people along the way. But that journey is unique in itself. It also, as you can see here, and as I see some care partners in our session this afternoon, is that it's emotional toll. It's hard to manage everything. You want to do the best we can. We also want to do the best we can, but we want to respect our loved ones and what they're managing every day. And also balancing what you're moving forward with your own self-care. Do I go to that doctor's appointment? I'm not sure if this is the right time. And so how do we balance that? But managing all of that, and it's easy to micromanage it all, very easy. But having that communication with your loved one is paramount. Talk about it. Talk about how each other can help each other. Ask for help. Ask for help. Reach out. You will see later in the presentation of how much help is out there. So be reassured that's the case. But also make time for your own personal health. You need to reassess that. Do your best. You do your best to reassess that so that you're in a very strong, good place or helpful place that you can be, so that you can help your loved one, but also that you can take care of yourself, right? That's so, so important. So there's supportive care resources that are so important. And I know we have many support groups that go with initial diagnosis to care partners, to lung transplantation, to our veterans living with ILD. And we have a grief and support program as well. So make sure, we have all of that encompasses managing all. So we want to make sure that we provide that. We have a women in ILD support group as well, which is unique journey in itself. And with that whole process, if you need to find outside resources in counseling and therapy, go for it. It's okay to reach out in that way. We're happy to help along the way. But that's often, I hear, a huge help for folks. And also the peer-to-peer conversations. So support groups and having these conversations. Our open forum meetings are electric of what one goes through can help another and vice versa. And also being mindful of what every day looks like for you and managing your stress along the way. And supportive care, and part of that is support group. Well, why do we do this? It's that approach, and you'll see it, the very educational therapeutic approach is understanding what you're dealing with in terms of interstitial lung disease and gathering that as knowledge to be empowered. And so along the way, you have this conversation with others that are walking this journey. Each is very unique, but understanding very tacitly of what one goes through. And so you feel comfortable, you feel safe in having these conversations. The emotional and practical aspect of it, we had mentioned the edutherapeutic approach, focusing on education, but also integrating the therapeutic aspect of it. We bring in, and this is also other support groups along the way. We have providers, researchers, other patient advocacy organizations to help along the way. I mentioned about the open forum format, which is very dynamic. And these platforms some are in person, some are in virtual, most are in virtual, and also in hybrid platforms. So this helps with family dynamics. How do I talk to my grandkids about it? How do I manage a daily routine, and what does that look like? And minimizing your stress as much as possible. You're building relationships along the way, open and honest conversations. That is no doubt about it. We have very honest conversation. And actually, through this process is we become friends, right? And you get in contact with folks, and you pick up the phone, and you have a friend to talk with. So of course, gathering all this practical, important information, including clinical trials. For patient, you're connecting with supportive care. What are these strategies? You are looking for ways of having to manage every day and conserving energy, establishing your routines. And, you know, like I said, mentioned before, things that you can control and things that are a little more difficult, and having that support along the way. Stay informed, stay connected. That is that extra layer of foundation in every step forward. Our care partners, and I will say it again, are our heroes. And supportive care for our care partners is essential. And how do we manage that, what I can and what I cannot do in the boundary aspect? Ask for help, right? Manage time for your personal health care. So what is important of communication? I've said it several times, is communication is so important. Talking with your care team, talking with your family. But in this instance, in the appointments, you know, perhaps you have your family with you, or a loved one, or your care partner. But talking with and open lines of communication with your care team is really important, and managing these difficult conversations. So what are helpful and practical resources? So practical resources, there's also a balance of this. Is you getting this information, take one step at a time. Do your best to take one, because this in itself can be overwhelming. So do what works best for you and your care partner in moving forward with everything in trusted organizations. That's very important. And what does this look like financially with medications, etc.? Pulmonary rehab and clinical trials, very important. And what does it look like for transportation and oxygen and the logistics of it all? I know you all are nodding your head of folks that are on oxygen. It is managing that way in terms of what works best for you. So here are helpful resources, of course, Temple Lung Center, whatever healthcare center you are working with, of course, Wescoe Foundation, Pennsylvania IPF Support Network, Pulmonary Fibrosis Foundation, American Lung Association, and PF Warriors. And proudly, we all work very closely together to make sure that the patient and care partner needs are met. So these are very, very important. So what are these final thoughts? You're not alone. You're just not alone. Reach out, get connected. That support and community engagement and outreach is so, so important. And like I said, mentioned before, small steps, take small steps, one step at a time, what works best for you. Reach out, stay connected, and advocate for yourself. We're here with you guys along the way, every step of the way. As always, reach out, you know where we are. And if not, pick up the phone, email me. I'm happy to help any way I could possibly can. So thank you. Thank you so much. And I'm going to stop sharing. So the next part of our presentation, part of our presentations is there's opportunities for a lung transplantation. So we have Dr. Criner, Rachel Criner, talking about lung transplant.
I'm Rachel Criner. I'm a pulmonologist at Temple, and we're going to talk about the role of lung transplant in interstitial lung disease. So we're going to review why do we consider lung transplant and when to consider it, and then we'll talk about the actual evaluation, wait listing, the surgery, recovery in the hospital, and then life after transplant. So why do we consider lung transplant? So I know pulmonary fibrosis or interstitial lung disease has already been reviewed, but what I really want to hammer home is, why do we consider transplant for this disease? Why is interstitial lung disease the #1 reason to be transplanted in the United States? And it really boils down to the prognosis of this disease is quite poor. So median survival for anybody of any cause of pulmonary fibrosis is about 2 to 5 years from the time of diagnosis without medical treatment. But our medical treatment are just antifibrotics, so nintedanib or pirfenidone, and all those do is slow down progression. So we're often turning to transplant in this disease. The average survival for a lung transplant patient, no matter what reason that led to lung transplant, is 6 years. So when you're faced with the disease of 2 to 5 years prognosis, the 6 years really do matter from a transplant perspective. So when do we consider transplant in this disease? So anytime you have symptoms that are worsening, as well as objective data showing that you're worsening. So what do we mean by objective data? So those are your pulmonary function tests that your lung doctors are getting so frequently. We're looking at 2 measurements, something called forced vital capacity and diffusion capacity. Any sign of those decreasing, even if it's a 5% drop, we start to worry. If you're imaging, so your CAT scan is showing worsening scarring, if you're having symptoms worsening as well, so you're more short of breath, or you're having more flares, or your cough is unrelenting. We also consider transplant anytime you need oxygen. So whether it's at rest or with exertion, anytime you need oxygen, we should be thinking about transplant. There are specific diseases within interstitial lung disease that we know are very aggressive. So there's a type of disease pattern called usual interstitial pneumonia, or UIP, that's associated with idiopathic pulmonary fibrosis, which means there's no cause, but it's also associated with other types of lung disease, particularly those linked to rheumatoid arthritis or familial causes. UIP pattern means you have either biopsy finding that shows this UIP, usual interstitial pneumonia pattern, or you have specific CAT scan pattern that's associated with UIP. And then anyone with a connective tissue disease, so your pulmonary fibrosis might be from scleroderma, or it might be from Sjogren's. Those types of diseases often have multiple organ involvement, particularly your esophageal tract. That doesn't mean that transplant's a no, but it just means that transplant planning becomes more complex. So we want to see you early. What's really important to know about transplant is that every center is different. So one center might tell you no, but another center might tell you yes. So just because we might think a certain way doesn't mean that everyone else is going to think the same way. So how does the actual evaluation process happen? So the first thing is that your lung doctor has to send you to a lung transplant physician, where they'll review all your data and talk with you about the risks, the benefits of transplant, what the process is like, and whether or not transplant is the right step for you. If the agreement is to proceed with an evaluation, what it consists of is really, like we call it, an astronaut going to space. We need to make sure that, yes, we know your lungs are sick, but is the rest of your body, your heart, your liver, your brain, your vessels, are they all healthy enough to withstand the demands of surgery? The whole process itself usually takes about 4 to 6 weeks, but it can take a few months if we find problems along the way that we need to further investigate. It consists of several lab tests, imaging tests, procedures like heart catheterization, swallow evaluations, physical therapy evaluations, and then several consults. You're meeting lots of people. You're meeting the cardiothoracic surgeon who does the actual transplant surgery, a cardiologist, a GI doctor, speech pathologist, physical therapist, nutritionist, pharmacist, physical therapist, which I might mention, nursing, just to show that there are several people that are involved with this process. At the end of all of the testing and evaluation, we have a weekly meeting, and most centers meet every single week, where they review the candidate and decide, yes, you're a candidate for transplant, we're going to put you on a list, or 2, you're not a candidate for a specific reason, or 3, we found something on the evaluation, we need more testing, or the patient needs to meet more people before we can make a decision. So how does the waiting list work? So once you go through the evaluation and we decide that you're a candidate for lung transplant, you get put on this wait list. It's a national wait list managed by UNOS, or United Network of Organ Sharing, and you get a score called composite allocation score. The score goes from 0 to 100. The closer you are to 100, that means typically the sicker you are, and usually the more urgent you would get a lung transplant. There are several factors that go into your composite allocation score, and all of those testing values that we're gathering go into that score. Average person in the United States waits about 90 days or 3 months for a lung transplant, but it varies from person to person. Some patients wait just a couple of days. Some patients can wait several months for a transplant. So what are you doing while you're waiting? we are trying to make sure that you're staying as healthy as possible. It's hard because you're very sick and you're very short of breath and often on oxygen, but we encourage people to stay as fit as possible, doing as much pulmonary rehab as well as physical activity at home, and really keeping up with their nutrition. Because with this disease, as it progresses, people tend to lose weight and a dangerous amount of weight loss. So we're wanting to make sure that your weight is staying stable as much as possible. You'll frequently see your transplant team, sometimes on a monthly basis while you're on the wait list. If you ever get hospitalized, it's something that the transplant teams need to know about. And you could get a call at any time. It could be in the middle of the night or during the day. A call can happen at any moment for a transplant once you're on the waiting list. The surgery itself is a day-long surgery. So you could have a single lung transplant or a bilateral, which is a double lung transplant. You'll go into the surgery knowing which one that you have been listed for. Every center is different in terms of how they do their incisions. So on the left picture is a thoracotomy. So those are single incisions per lung. And then this picture here is something called a clamshell, where the entire chest is open. Every center, like I said, does it differently. The recovery process first starts in the intensive care unit. Patients are typically there for about 3 to 5 days with a breathing tube for about 2 to 3 days. They then go to the step-down unit anywhere from an additional 1 to 3 weeks. Step-down units, I think, are the hardest. We're really encouraging you to get out of bed early, walk around, trying to test out your new lungs. The goal is to go home. So we're really encouraging you to get out of bed, work on your nutrition, work on your physical therapy. The caveat, though, is that complications can happen. So some people might not be there for the 1 to 3 weeks. They might be there for several weeks, sometimes a couple of months as they recover. The biggest part of your recovery after a lung transplant is, one, making sure you can take the new medications. So 3 of them will be anti-rejection that are lifelong. Then you'll be on antibiotics as well as other medications because the transplant rejection medicines can cause side effects. You'll also be working on your physical therapy, and you'll also be working on your nutrition. We want to make sure you can swallow okay as well as gain weight. So what's life after lung transplant? So this phrase, a new phase of life with new responsibilities, comes from the Pulmonary Fibrosis Foundation. And it really highlights that it's a second chance of life, but you have new priorities sometimes depending on what your interests are and your hobbies are. So our goal is that you can live your life again, that you maintain your nutrition, maintain your exercise. But we also are cautious of certain risks in your life. You can travel again, but we encourage you to stay away from large crowds. You can't be around anybody sick. There's certain foods you need to avoid. There's a whole list of do's and don'ts, but you can certainly have your life back. One of the biggest things you'll have after a lung transplant is frequently seeing your transplant team throughout the rest of your life. We're constantly going to be monitoring you for any risks for infection, rejection, or side effects of the medications. But typically over the next several weeks to several months after your discharge from the hospital, you're able to gradually return back to your life. Thank you.
Thank you so much, Dr. Criner. Thank you, everyone. This is so much information, and it's important for us to have this conversation of questions and answers. We're a little bit behind schedule. So if you could stay with us, we'd love to have you along with this valuable information. If it's okay, it is okay if you need to hop off. This, again, will be recorded. Just want to let you know in our next steps. So we are going into our Q&A part of our seminar this afternoon. And we're so lucky to have Dr. Rachel Criner with us. We have Dr. Aamir Ajmeri with us, and we have Dr. Parag Desai with us, and Dr. Pourshahid with us. So we have so many experts to navigate these questions. Thank you. Welcome, guys. So what I'm going to do is I'm going to go right to the Q&A, and then whoever wants to field that question, we could move forward. What I'll do is kind of navigate that along the way. One of the question is hi, Dr. Criner. One of the questions is, how important are toxic exposures in causing ILD? For example, we hear about the forest fires, chemicals such as insecticides or herbicides, benzenes. Do we know what the incidence of ILD, increasing the cause of that with the dirty air, right, of what that is? Do you have any thoughts about that? Dr. Criner, would you like to answer that? Oh, you're on mute. Whoops.
Sorry, I have to use my phone, so I'm like trying to navigate a little bit. Yeah, so in terms of like air quality and the like pesticides, I don't know too much of those contributing to ILD. It's more of like the dust exposures, asbestos exposure, silica. So a lot of people who work in construction or cut stone or woodworking, pottery. It's a good question about the air quality. I haven't come across that. I don't know if others on the call have.
Anyone
Certainly,
else have
though,
any?
it can exacerbate your symptoms, like your breathing, your cough, but specifically causing lung fibrosis or lung scarring, that I don't know too much if that has much contribution.
Thank you, Dr. Criner.
I can add on to that, Jen. I was actually just reading a paper on this like 1 minute ago. So that, you know, I think they extrapolate some stuff from the World Trade Center attack, and like those type of inhaled kind of particulate matter can cause worsening lung disease. I don't think there's data on like the percentage, but we do know like dust and kind of poor air quality and inhalation of like volatile compounds can definitely cause worsening lung disease. So absolutely try your best to avoid exposure to that.
Understood. Thank you. Thank you. One question we had along the way too is which is better, right? Of the OFEV or pirfenidone? You know, could anybody navigate that question?
I guess I can go first on this one. There is no head-to-head comparison on OFEV and pirfenidone, and we're separating out IPF versus non-IPF ILDs. So, you know, the data for IPF shows that both medications achieve their primary goal, which was to slow the rate of lung decline. The data is better for OFEV for non-IPF ILDs. And there's still some data on pirfenidone as well. But I think we're really excited about all the new medications and all the trials that we have ongoing. And I'm sure we talked about Fibronir and which is the name is nerandomilast. So we're anxiously awaiting that data to come out. But I think that's going to be the next big thing.
Excellent. And here's the $1 million question. When do we know that the FDA approval is for Fibronir or nerandomilast? It's just to be determined. We just have to wait.
Unknown, unless somebody knows somebody in the FDA with inside information. But
Yeah.
Who knows? The data for the IPF trial, where they met their primary endpoint, was September. So we're going on 7 months of FDA review, but we have no insight until where it actually is in the process, unfortunately.
Right. Understood. Yeah. That one question is, okay, so we'll just have to wait and look forward to when that happens. Here's a great question. Is liver fibrosis also common in ILD patients? That's interesting because the wonderful folks that we work with, there's some instances of that, but you know, who knows if there's any relationship. Any thoughts about that?
So there is a familial disorder called short telomere syndrome, which can impact the lungs to cause lung fibrosis, the bone marrow as well to cause cytopenia, so your cell counts will be low, and can also cause cirrhosis. It's a rare disorder. We do try and screen for it in patients that we might be suspicious if they have a strong family history of pulmonary fibrosis. And then other circumstances where I've seen it, if someone has developed pulmonary hypertension, so if they have interstitial lung disease that's led to pulmonary hypertension, that can cause a lot of kind of back pressure on their liver. So some people might develop some liver disease from that as well. But those are kind of the two instances where I've seen it.
Excellent. Excellent questions. I mean, leading the charge, patients and care partners, just really trying to get as much information as possible. So thank you guys so much. I'm going to end with the last question. I want to be respectful of everybody's time. Is there data to show the impact of acute exacerbation incidence and mortality in ILD patients by COVID, from COVID? These are pretty loaded questions, but very good ones.
Dr. Desai, hand off to you.
Thanks. I don't think there's exact data, but I think we do know that any viral precipitant can exacerbate your underlying, lung problem through various inflammatory pathways. So can COVID make my pre-existing lung disease worse? Yes. Can COVID maybe in a subset of our patients highlight that there's background lung disease that now kind of becomes more evident? Yes, as well. So I think, oftentimes when we see patients and they have had a viral infection, maybe COVID, maybe something else, then they come in and someone's told, oh, you have scar in your lung. And then you kind of see the scar either progresses or there's other things. And historically, we go back and ask them more questions in terms of what has been going on, what has been exposed to, what's been happening from an infection standpoint in their lifetime. Then a story develops that might predispose them to have an ILD that just got more evident because the viral infection happened. I think, as I said in one of my slides, I think there are two things that are there. One is your susceptibility to get an ILD through various factors, and then an injury that occurs that leads that susceptibility to kind of expose itself. And maybe a viral infection, just like COVID, is part and parcel of what happens in some of us. So no, I don't think there's anything that says direct evidence. I think some papers are biased because in those patients who have ILD after COVID are selected for those patients who had symptoms and then, were studied over time. So.
Excellent. Thank you, Dr. Desai. And if it's okay with you, one more question. This is a bonus question. We'll just add this on and then we'll wrap it up by 1:40. Again, I want to be respectful of everybody's time. Here's a question which we often hear is it possible to use too much oxygen? And should change liters per minute during sleep as compared to daily activities? So adjusting the oxygen levels. Any thoughts about that? Dr. Desai?
Sure. I mean, I certainly one can use too much oxygen needed. I think that's why we kind of get a sense of where we are. I think what you need oxygen for depends on, oftentimes we'll use oxygen, not necessarily for the lung disease, but the health of other organs, predominantly the brain, the kidneys, the heart, and such. So I think maintaining some steady level of oxygenation is important. And the amount depends on what that is needed, right? Oftentimes I'll tell patients, 88% is okay for you if these other parameters are met. Are you feeling fine? What's going on? What does your heart test show? What does that show? And that might allow us to tweak what that oxygen level is too. I think this is where a role of a sleep study becomes important, or at least an nocturnal pulse oximetry, so we can titrate what you need in terms of sleep and not just guess at it and kind of go from there. Obviously, sleep physiology is complex and different, so you might have differences in terms of what you need in sleep versus the rest of the day, but we can titrate that too based on studies that we have.
Excellent. Thank you, Dr. Desai. This afternoon, a wealth of information, and having you all here with us in learning so much more. There was some information that definitely can be helpful to so many. So to remind you, we will have a recording of the seminar, so stay tuned for that. We talked a lot about topics of understanding ILD, symptom oxygen management, what are PFTs and understanding those numbers, pulmonary rehab, how important that is, clinical trials, patient and care partner support in navigating pulmonary fibrosis along the way, and lung transplantation. And some of the questions, follow up, reach out to us, and we have them noted. Just feel free to reach out to have any other questions that you might have. Dr. Criner, Dr. Ajmeri, Dr. Desai, thank you so much for spending time with us of this interactive conversation. It's so important in that engagement in asking these questions. Folks are really yearning to learn more about. So thank you so much. Temple Lung Center, just thank you so much. This opportunity to always have this time with you, work together with you, and supporting patients, care partners, and families along the way. All the information is here to reach out. We're here to help along the way. Pick up the phone, email, and it's a true honor to be with you guys this afternoon. So we'll end it here. Enjoy the rest of your day, and stay tuned for the recording, and we will see you soon. Thank you, guys.